Hello, everybody. Thanks so much for joining us today. My name is Jen Ridenauer. I'm Product Marketing Lead at Viz AI. I'm honored to be joined today by Dr. Suzie Bash and Dr. Kevin Abrams. Today, we're going to talk about a background on AI, go through a summary of clinical applications, including some examples within clinical practice. With lots of content to cover, I don't want to delay. I'd like to pass it right over to Dr. Bash to get us started.
Thanks so much, Jen. Yes, my name is Suzie Bash. I'm a neuroradiologist at RadNet. In this talk, we'll discuss an overview of the AI market space, as well as challenges and opportunities for AI integration in your radiology clinical practice. All areas of our lives impacted by technology are right now in the process of being transformed by AI. So we'll discuss the present and future of the broad AI market space, and then narrow down more on imaging AI. I think we can all expect AI-enabled robots to become part of our everyday lives at some point in the future. Sophia here has silicone skin. She speaks with 62 facial expressions, and she remembers her interactions with other people. Right now, computers are actually better at pattern recognition than humans, but humans are better at global reasoning. You can see here this AI program did a fairly good job of generating an AI image from the pattern of a photograph of me. But here's some of the problems. So this AI could detect that this is me here, or this is a person here, there's water here, there's sky here, and a sun, but it wouldn't really understand what's unusual about this picture, whereas humans could immediately detect that the picture is upside down. And AI isn't always robust. It fails sometimes. This was a fully self-driving Tesla autopilot that resulted in an 8-car pileup in San Francisco. So what is the purpose of AI in radiology? Well, I believe it's to increase accuracy and efficiency, which we generally term non-interpretive AI, and also to provide clinical decision support, which we generally term interpretive AI. I believe every single imaging study will first undergo AI analysis before a human has ever seen it. In addition to AI screening for disease pathology, I think all quantitation will be completed by a computer alone in the future. And also, if I were going to rank what would happen first, I would say probably plain film studies such as chest X-ray for lung disease and endotracheal tube placement will likely have fully automated AI interpretation first, followed by mammograms. So AI applications can be applied before, during, or after image acquisition. Some of the AI tools that can be applied before would be things like scheduling, insurance authorization, billing, mining PACS and medical records, and trying to prevent no-shows. I work for RadNet, which is the largest outpatient imaging enterprise in the United States. We do probably 8.5 million exams a year, and we actually use AI for several of these things, for scheduling, insurance auth, billing, and to help prevent no-shows. AI optimization during image acquisition would be things like optimizing image display, deep learning reconstruction, and synthetic imaging. And so let's sort of start here with optimizing image display. AI can do automated image alignment. It can automatically segment. So here it's segmenting the volumes here of the lateral ventricles. And then it can do automated subtraction maps. Here's the current, here's the prior, here's the heat map overlay. You can see how this would be very useful in things like patients with dementia or NPH. This happens to be NeuroQuant CT. And it's also very good at 3D anatomy. It can label the ribs for us, which is hard for us to do in the axial plane. It can actually splay out the ribs. And so you can see how this would be very useful if you're trying to detect osseous metastases in the ribs or bone fractures. AI provides anatomical image intelligence with multimodal image fusion and quantification, fusing here the PET to the CT. It provides cinematic rendering with photorealistic 3D visualization of CT and MR images, combined with Microsoft HoloLens 2 in this particular case. You can see here what some of these images look like. It's pretty impressive here. Now, a very nice view of the rib fractures. Here's the cerebral vessels. And so you can see that this is a fairly impressive technology. Now, another thing that you can do during image acquisition is deep learning for reconstruction. Deep learning for reconstruction is a very exciting AI tool. This is really one of the first things that I think is driving AI into standard of care for imaging. It allows for superior perceived image quality, higher perceived signal to noise ratio, higher perceived spatial resolution, higher perceived contrast to noise ratio, reduced artifacts, reduced dose, and it can enable faster scans. So how does DLR work? Well, it doesn't actually accelerate the scans itself. Basically, imaging facilities alter their protocols to decrease scan time, which we call fast scans. And then you can accomplish this acceleration by different means. Then the DLR is applied to the fast data set to restore image quality by denoising and often sharpness enhancement. The vendor neutral solution on the market space right now is Subtle Medical. They were actually first to market space, but it was such a good idea. All the OEMs have then followed suit, different stages of fruition with FDA approval, but a lot of them are now FDA approved. So an advantage of a vendor neutral solution like Subtle Medical is they operate in the DICOM space rather than K space like OEMs. So they can be applied to any scanner brand of any age. And that allows a virtual upgrade to legacy scanners. So it really improves the ROI by extending the scanner life. OEM's DLR products produce beautiful images, but right now they're limited only to their newest scanners at this particular point in time. So we can take a routine MRI exam from 30 to 40 minutes down to 15 minutes, and that's not just scanning time, that's on and off the table time. This makes a big difference in workflow. This is sort of what it looks like. Here's a standard image here acquired in 9 minutes. If you change your protocol and accelerate, you can get that down to half the time, but your image becomes very noisy. And then you restore the signal to noise ratio and other aspects by using deep learning reconstruction to apply it to this fast images. This is what you get. Look at the difference in gray-white differentiation compared to the standard image. Here's another example, standard, fast, and fast DL. Again, look at the gray-white differentiation compared to the standard of care despite going 50% faster. I like this case. This is a patient who had multiple small intracranial metastases. You can see this cortically based met is very difficult to see on the standard. You can accelerate your protocol 50% faster. And actually, when you go faster, it actually increases the contrast to noise ratio, but it makes the image noisy. You can then take this fast image, apply deep learning, and you get a bump then in signal to noise ratio while maintaining that high contrast to noise ratio. And now all of a sudden you can see how easy it is to see these metastases, and detecting these early can mean the difference of saving a patient's life. So this is a very useful AI tool. Here's again standard of care. We've gone 72% faster, applied deep learning, and this is what we get. Here's standard, and here's after deep learning, just a tremendous difference here in image quality. Here's another example. There's the standard, and here's the fast DL. Here's, if you look at the hippocampus, here's the original image, and this is after deep learning is applied. Again, here's the original. We got it down to 5 minutes, but we have a noisy scan, apply deep learning, and here you see what it ends up looking like. Again, the original scan took 28 minutes. This is 7 minutes. Look closely here as I apply this animation, and this is what it looks like after deep learning in this patient with liver mets. You can see why this would be very useful in the pediatric patients. They may have a hard time holding still. 24 minutes was the original. We got it down to 6 minutes. We've got a noisy image here, and look as I do this animation, and the deep learning corrects the image quality. And here we went 75% faster and with less radiation dose, but you can see that the images look very good. You can also use AI during image acquisition to create synthetic images. This is a product in development. Here's the actual stir, and here is a synthetic stir. Look how beautiful this looks compared to the actual stir. So the way this is done is you create the synthetic stir from a T1 and T2 input. Here is the original stir here, and this is the synthesized stir here. Look at the difference here between the original, and this is essentially 100% acceleration. You created an image out of nothing and saved a lot of time. Stir sequences in spine studies are our longest sequence, and they're very prone to artifact, which is why Subtle sort of started with the stir as their first synthetic sequence. Again, T1, T2 input, here's the actual stir, and then look at the synthesized stir. Just look at the CSF here and see the difference between the actual stir, really helping eliminate that artifact. Here's a patient with a marrow replacement in the S1 vertebral body, and here is the synthesized stir. See, all this artifact here is gone on the synthesized stir. Here's again the original stir, and this patient has got a couple of compression fractures in the synthesized stir. This is a patient with discitis osteomyelitis, the original stir, and the synthesized stir. We preserve all of the imaging features, but increase the signal to noise ratio. Here's again the synthetic stir that's really has poor quality through the cord, and then here's the synthesized stir. Now, AI can also be applied after image acquisition. We can do this for things like cancer screening, triage apps, quantitative volumetric imaging, and natural language processing. So with cancer screening, AI can detect prostate cancer. It can measure the volume of the prostate and also the volume of the tumor. There's another program here that's also evaluating prostate cancer. It can also detect breast cancer early. RadNet acquired or partners with many different AI companies. This happens to be one they incorporated called Deep Health. It will detect breast cancer 1 to 2 years before expert radiologists. Here, this cancer was missed by the human at 1 year, but by 2 years, it was detected by the human, but the AI picked it up first. It doesn't matter how you run this data through, if the AI tool always beat out expert readers when coming to detecting cancers earlier. Again, because computers have an advantage with pattern recognition that will obviously help save lives. Here's another company we incorporated that's in development for detecting lung cancers. Cortex has a OnQ Neuro product that will segment and detect tumors as well. And then the other big thing is triage apps that can be applied after image acquisition. This happens to be Viz product. You can see here that it's detected a large vessel occlusion here on the left. This is a pre-packed solution, 63 seconds between the time the scan was performed and the alert is made to make everyone aware. So it's an AI-powered notification for LVO and CT perfusion. It uses high-fidelity mobile image viewing, so everyone can view it through a HIPAA-secured mobile app on their phone. It provides real-time patient information and HIPAA-secured communication between all of the members of the stroke team, including the neuroradiologists, neurointerventionists, neurologists, etc. This is their perfusion module. And basically, it saves 102 minutes from door in to door out, and 87 minutes are saved in the door in to groin puncture. It's all about getting to thrombectomy early in terms of outcomes. So this software, when it's utilized, will decrease the neuro ICU length of stay by 3.5 days and the regular hospital length of stay by 2.5 days. This is a significant cost savings for the patient, but more importantly, it really helps improve their cognitive function, which is what we really care about the most. In addition to the intracranial hemorrhage detection, there's also aneurysm detection, which again will alert and prioritize. And then outside of the brain, AI tools can detect aortic dissection and also pulmonary embolism. Now, another AI application that you can apply after image acquisition is quantitative volumetric imaging. This is what one company looks like, Cortex. It's another company, Icometrics, QuantumND, Combinostics. Darmian is actually in development here. But why is it appealing? Well, it improves diagnostic accuracy. It enhances clinical value by allowing you to monitor disease activity. It helps with reducing reader subjectivity, which is a very big issue in radiology. Our referrers don't like it when our interpretations sound different between our colleagues. And it can impact disease-modifying therapy for patient care. So like if you take here, this is a 73-year-old with memory loss as an example, mild to moderate right temporal lobe atrophy. This happens to be NeuroQuant. This happens to be Icometrics. Quant post-processing was done. You take a closer look here, and it calculates the volume of pertinent structures in patients with a potential dementia. So hippocampi, entorhinal cortex, the ventricles, the temporal parietal frontal occipital cortices, anterior posterior cingulate gyri, and it plots it on a graph here. So anything in red is more than 2 standard deviations outside the mean, and anything in pink here is also 2 standard deviations. And here's another report here where again, you're given the normative percentile for different areas and a spider graph here pointing to what lobe is most affected. This is a triage brain atrophy report where you get more structures here. Anything in red is statistically significant. This patient then went on to have an amyloid PET study. Here's the PET CT fusion. Here's the PET MR fusion. Diffuse binding of the amyloid tracer to the cortex. So this patient, in fact, had Alzheimer's disease. So we can use quant for many different things: dementia, multiple sclerosis, epilepsy, pediatrics, traumatic brain injury, neuro-oncology, and spine imaging. I'll just give you another example here of multiple sclerosis, where it can detect individual lesions and color code them according to location in the brain, and more importantly, the dynamic change over time, so we can see which lesions are new or enlarging and which are shrinking over time. This is what you would look at on your PACS, this sort of cine image here, and you can see the new and enlarging plaques and shrinking plaques that are in blue. This is what an MS report looks like. This happens to be NeuroQuant. You get the lesion burden by volume, which is really the most important thing. Here's the current, here's the prior. It also gives you a lesion count. But as plaques enlarge, they can become confluent and actually artificially, drop the plaque count. So I always rely much more heavily on the volume. And then more importantly, it tells you what's new, enlarging, shrinking, and stable. And also the other structures like cerebral cortical gray matter, white matter, thalamic volumes, etc., current and prior. And then you can get plot graphs as well, tracking from the prior change. We can use it in epilepsy. This particular patient, the right and left hippocampi were both within normal limits, but the asymmetry index was out of the normal limits. So this would be making you think that this patient could potentially have an early right-sided mesiotemporal sclerosis. Here's icometrics report. And then it can also be used in neuro-oncology. This happens to be OnQ Neuro. Sometimes it's hard to tell by imaging alone. In fact, it can be impossible to tell what is recurrent disease versus treatment change. And so tumor segmentation can be done by the software. It actually does a very good job of segmenting the tumor and the surrounding flare hyperintensity. Here's RSI, which is sort of a high-level diffusion showing active residual tumor here. And so these are the type of reports that you can get. Here's a preoperative patient, and this is after segmentation is done. This is a postoperative patient. And you can see here the enhancing tumors in red. The whole lesion was a combination of the enhancing tumor, the necrotic core, and the surrounding non-enhancing flare hyperintensity. And resection cavity is eliminated from the whole lesion size. And then you can see how the enhancing tissue is changing over time in the postoperative setting. Here's again a look at before and after segmentation. And this is just sort of a dynamic view of what you see after the segmentation has been performed. This patient is here a pre-op and post-op segmentation. And then AI can also be applied after image acquisition for natural language processing. This particular company, Rad AI, can learn the style of individual radiologists through looking at multiple reports of theirs and take the findings and then create the impression. This can save radiologists a lot of time. And it does it in your own particular style, which radiologists really all like. Everyone is comfortable and likes their own particular style. So this could be a very useful feature. Now let's move on to some of the challenges for radiology AI. And we can look at this from the perspective of the radiologist, the imaging enterprise admin, referring clinician, and the vendor. So from the perspective of the radiologist, I think probably the two biggest challenges, when I think about it, are time and trust. Will it cost time to dictating speed? Most radiologists are paid on an RVU basis, and even if an AI app provides value, if it costs them a lot of time, they're probably not that interested in incorporating it. And so will it take time to learn about products? Will the workflow integration be seamless? And is customer support available and efficient? But going back to the productivity, it actually can save time. So in the realm of quant, you can actually read 38% more reports per hour when you use quant with a pre-populated reporting template. So 13 in an hour as opposed to 8. And then this is what the pre-populated reporting template looks like. This is a summary of all the important findings that can be copied and pasted into your report if you would like to. And then the other big issue for radiologists is trust. How accurate is the product? How reliable is it in terms of failures? How consistent is the software in terms of false positives and false negatives? And what is the value of the product? Can we trust it? As products develop, they mature over time and get better over time. And so that's a wonderful thing. So I've noticed that there's been a big trend of moving from machine learning to deep learning. This happens to be an MS patient, and you can see it picks up a lot more plaques when you convert to deep learning. And then does the product really have value? So here we're seeing anything in red is getting bigger, anything in blue is getting smaller, the cortex is getting smaller, the ventricles and the sulci are getting bigger, and this can provide value. Again, value in terms of being able to see what's increased or decreased in plaques in this particular patient, because with differences in slice sampling and head angulation, it is very difficult to detect, particularly if the patient has a very large plaque burden. It can also improve detection of disease activity. Staying in line with this MS case, 24% of radiologists, when they're just looking at the exams with their eyes, will say there's active disease, meaning enlarging or new plaques. But when you apply quant software, that number goes up to 76%, and that can impact disease modifying therapy. So my referrers really love to use quant for their MS cases. It can also result in 22% improvement in intra-reader variability and 23% improvement in inter-reader variability. And then from the perspective of the imaging enterprise, the admin, I think some of the things that are challenges that they're thinking about is, will the solution align with the practice goals? So certain AI tools are more practical in the outpatient setting versus the inpatient setting. So you need to figure out which is right for you. Will insurance reimburse the AI tool? And if not, who pays for it? Should the imaging facility do a patient pass-through, which some are doing for certain AI tools successfully? And what is the ROI? Is the added value and referral benefit worth the product cost? There are issues to consider with the contract, time investment for training the techs, marketers, and the MDs, and how easy and seamless installation and rollout is. And then from the perspective of the referring clinician, it's really about education about the clinical utility of the AI solution. Referring physicians often don't know what the right product is to use and if they should be ordering it. And then from the perspective of the vendor, really raising awareness of value in radiologists, the referrers, imaging facilities, and patients, educational initiatives, social media, and internal champions that are believers in the product and can sort of spread the news about that through their imaging enterprise. These are all challenges for the vendor. Also reimbursement challenges. It may be beneficial for vendors to have a CMS advocate. Viz was the first company that was eligible for a new technology add-on payment because they were able to demonstrate that they were improving cognitive function and outcome in stroke patients by getting them to the table earlier for thrombectomy. And then the other challenge is getting referrers to agree to an AI-based imaging tool and expanding and improving the product line. Now, there are opportunities here. So opportunities for vendors would be to establish trust and with customers and clinicians. And that means a commitment to constantly improving product accuracy and also clinical validation trials. Radiologists want to know that these products have been validated in clinical trials. And then to really demonstrate value by developing new clinically relevant products, develop products which differ from competitors, and the simplicity of the user interface. This is a bigger deal than you think. If you have to use outside hardware, that presents a problem for RadNet. We have 355 imaging facilities, so that wouldn't be a great solution for us. Other opportunities would be educational and marketing outreach. That means clinical meeting presence, social media, education, website enhancement, and physician outreach. And I put in here specifically resident training programs. If you poll residents, almost 100% of them want to learn about AI in their residency. But in truth, very, very few residents are getting trained in AI during their residency. So this needs to change. Also, other opportunities would be collaborations with other AI companies, whether it be OEMs or private vendors, and a platform exposure to sort of fill the niche. Not every company can do everything, but if we work together, we can provide sort of a multi-solution through potentially a single platform. Long-term goals would be to develop products which will drive imaging AI into standard of care. So what is hype versus reality? Vendors have very high value claims for their AI solutions, but how do we know if they deliver what's promised? And again, that gets back to the importance of multi-center clinical validation trials. I happen to be a big believer in this, so I've done some of these. Here we went 40% faster and then applied deep learning to the fast image. This was a prospective multi-center, multi-reader trial. These are the kind of trials that you want so that you eliminate bias. What we found was that the deep learning matched or exceeded perceived image quality of standard of care spine MR exams despite the 40% reduction, and it qualitatively outperformed standard of care for artifacts and signal to noise, and it quantitatively preserved. We used a SSIM, structural similarity index metrics, and it really suggests the potential for routine utility of deep learning MR in clinical practice. This was published in Clinical Neuroradiology. And then we were wondering if it's possible to effectively apply more than one AI solution to obtain the benefits of both tools while still maintaining image quality and accuracy. So this was another clinical validation trial, again, a prospective multi-center, multi-reader trial where we looked at patients with memory loss. We did a 60% acceleration, and then we applied deep learning, and we also applied NeuroQuant for quantitative performance both before and after deep learning. This was published in AJNR at the end of 2021. And what we found is that FastDL was statistically superior to standard of care for perceived image quality across every single imaging feature that we looked at. It was actually very impressive, the outcomes. The volumetric segmentation with NeuroQuant matched both before and after. So the top row looks like the bottom row because the quantitation was the same for both. So whatever the hippocampal volume was before, it was the same after FastDL, which really portrays the robustness of the quantitative software and as well the deep learning software. So deep learning reconstruction allowed 60% scan time reduction while maintaining that high volumetric quantification accuracy, consistent clinical classification, and perceived superior image quality when compared to standard of care. And it really supports the reliability, efficiency, and utility of DL based enhancement for quantitative imaging. And the hope is that shorter scan times may boost utilization of volumetric quant in routine clinical practice. Another one that we are working on here, or actually we've already submitted this for publication at AJNR. It's again a multi-center, multi-reader trial. And this was evaluating the synthetic STIR images that we talked about earlier. DL generated synthetic STIR spine images turned out to be superior in image quality to conventionally acquired STIR, suggesting the potential for routine clinical practice. So what do clinicians expect from AI companies? Well, they expect that vendors' AI solutions will do what they claim to do. They expect that, products that they incorporate, generally they will want them to be FDA approved or CE marked in Europe, and they would like them to integrate seamlessly in the PACS workflow without requiring external hardware. And they also want to be provided with good customer support. They want products that deliver value without costing the imaging company or radiologist money or time. In other words, a positive ROI. Thank you so much for taking the time to join us. Dr. Abrams will now talk about his personal experience with a triage app in his clinical practice. Thank you.
Thank you, Suzie, for that great introduction on AI in the radiology space. Now, what I'd like to talk about is our real-world experience with AI using Viz AI. So my first question is, does your daily work list look like this? You have a whole bunch of what we call red dots or red squares showing stat brain, stat chest, stat CTA chest, stat CTA neck, and then at the bottom you have a few routine cases. Seems like everything is ordered stat these days. Now, what happens if the last case on your stat list looks like this, a diffuse subarachnoid hemorrhage, or the last case on your routine list looks like this, somebody with saddle pulmonary emboli? Certainly you want to triage these cases towards the top rather than the bottom. So this is the Biz Platform. I'm showing it as the mobile app right now. However, they also have a desktop app that does the same thing. If you look, you have AI-powered large vessel occlusion, intracranial hemorrhage, PE detection, aortic dissection, and aneurysm alerts. These are the things you want to triage towards the top. Has an advanced mobile image viewing, which as you see, you can do your CTAs in any which way you want. The team can put in clinical information. And lastly, the chat function, which is full stack secure communication, HIPAA compliant, encrypted so that the whole team could be on the same page, on the same patient, communicating in parallel rather than in serial fashion. So let's start with a few cases. The first is an 85-year-old woman, history of atrial fibrillation on Eliquis in the outpatient setting. She was brought to the hospital via EMS with stroke symptoms of slurred speech and left facial droop. Here's her non-contrast brain CT. Now, if you look here, there's a hyperdense clot sitting in the right MCA trifurcation, and it actually looks like the clot may actually be in an aneurysm. The aspect score was 10. So we went on to do a CTA on this patient, and we get this alert. This will come on your PACS, will come on your phone, come on the desktop, wherever you'd like. This is the suspected LVO, and it goes to exact slice of where the suspected occlusion is. And here it is on our source images demonstrating the right MCA occlusion. We also get a second alert here. Besides the LVO alert that we see in yellow, we got an ANX alert in blue, which means it's detecting an aneurysm. Now, it's unlikely it's detecting the right MCA aneurysm, which looks like it has clot in it, but it was actually detecting a left PCOM aneurysm, which we'll see later. The Viz group starts texting and ensuing coordination of care between neuroradiology, neurology, nursing, and neurointerventional radiology. Again, parallel communication rather than serial communication. Here's the same patient, their CT perfusion. You could see on the bottom, the big area in green showing the acute ischemia in the right MCA territory. And the core infarct is calculated at 0, so this is a good therapeutic benefit ratio here. We also looked at the PCOM aneurysm, and there we can now see it on the sagittal and axial images. And here it is on 3D reformatted images. You could see the right M1 segment occlusion, as well as the left posterior communicating artery aneurysm. Patient goes on to thrombectomy by Dr. Debus. You could see the M1 occlusion. And with passing of a thrombectomy device, they were able to get an excellent angiographic result, a TICI-3 result. Not only can you see the vessels nicely, but now you see that aneurysm which had clot in it. Since they knew about the possible left PCOM aneurysm, they also injected the left side and showed the left PCOM aneurysm that was slightly irregular. This is the patient on 48-hour follow-up. All symptoms resolved. The patient was discharged. So does this parallel communication do the patient justice? Does it expedite patient care? And the answer is definitely yes. This article came out in the AJNR January of this year. It looked at Viz AI implementation of stroke augmented intelligence and communications platform in a comprehensive stroke network. This was out of the University of California, San Diego. They took 82 neurointerventional cases pre and post time periods. They found that a 39% improvement by using the AI augmented intelligence and communication platform, thereby decreasing door to groin times from 157 minutes to 95 minutes. This is huge when it comes to stroke care. Here's another patient that had picked up the LVO in the right MCA. You see the LVO and it goes to the site of the occlusion. But then when we did perfusion, we look at our motion maps, and having done perfusion now for over 20 years, I will say the most common sequence a patient will move on is the perfusion. And in the past, we used to have to say perfusion is limited or non-diagnostic by motion. And looking at this motion map, it almost looks like a seismic earthquake, I should say. You could see in all directions the patient is moving. We'd like to see straight lines here. However, AI in the automated motion correction in the background, this is not done selectively. It is automatically done. You don't need to do anything. It automatically will recalculate the maps and show you where your areas of ischemia are, which you can see here at 94 cc's and core infarct at 46 cc's. If you look at the qualitative maps, it also corresponds to that right MCA distribution very well. In the past, this would have been a non-diagnostic exam. How does it do versus other vendors? Well, they did a head-to-head comparison between Biz Perfusion and Rapid Perfusion. Dr. Noguera and colleagues did a head-to-head comparison, and Viz AI showed 50% fewer motion artifact errors than the competitor. Next patient is a 78-year-old with acute aphasia and right side facial droop. It started the day before, then it completely resolved, but then it recurred. Patient came in at this time with an NIH stroke scale of 3, essentially crescendo TIAs. The brain CT was negative. We look at the CT angiogram, this 3D representation, which we don't get immediately, but good for illustrative purposes, and it didn't show anything dramatic. We look at the perfusion, and it doesn't really look that dramatic either. It gets a Tmax of only 0.5 cc's. You don't even know if that's real or not. However, we then get the LVO alert, this big yellow border. Now it gets a yellow icon, and it goes to the slice of suspected LVO right in that genuinely left MCA. Now we go back and look at the perfusion maps, and you can see a perfusion abnormality in the left temporal parietal region, mainly in Wernicke's area, that rises to above Tmax greater than 4 seconds, but not quite Tmax greater than 6, because this is a near occlusion, not a total occlusion. Now that the AI picked this up and pointed it out to us, we can go back and find that near occlusive clot in the posterior division M2 segment of the left middle cerebral artery. The AI helped the radiologist uncover a potentially missed LVO. Now we can rotate that 3D CTA around and see the near occlusive clot in that M2 segment left middle cerebral artery. Patient goes on to thrombectomy. Now you could see there was a near total occlusion. You can see a very thin contrast going through the area of clot, but very poor distal perfusion. After just one pass of an aspiration catheter, they received a TICI-3 result. 24-hour follow-up, the patient's aphasia and all symptoms resolved. How good is the Viz AI LVO performance? Well, it turns out it's pretty good. They took over 2,500 patients across 139 hospitals, so not a single institution, but multiple institutions, and found 96% sensitivity and 94% specificity. How are radiologists in general picking up these CT angiography? How good are we picking up the LVO? Well, this article that looked at CTA only, but no CT perfusion, showed that in general, a radiologist is not going to miss an ICA occlusion or an ICA with M1 occlusion. When it comes to an M1 isolated occlusion, they found that it corresponded to about 37% of LVOs and about 18% of missed LVOs. Furthermore, when you get to the M2 segment, they accounted for 48% of large vessel occlusions, yet 82% of missed LVOs. That's a big missed opportunity. If you take the analysis of the odds ratio of missing an M2 versus an M1, it's almost 6-to-1. Similarly, if you compare a non-neuroradiologist to a neuroradiologist, it's also almost 6-to-1. So yes, we do need help. This I call my gallery of hemorrhage. So they do have an algorithm that picks up intracranial hemorrhage, and you'll see it's either a magenta border or this magenta ICH icon here, and it will pick up epidural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, large parenchymal bleeds, small parenchymal bleeds, as well as intraventricular hemorrhage, in this case, a combined intraparenchymal and intraventricular hemorrhage. The performance is about 85% sensitivity and specificity for ICH, and for subdurals, it is 91% and 96%. So let's go back to this patient that had a left thalamic bleed with intraventricular hemorrhage that we were alerted on. An exciting feature now that is under investigational use only, not FDA cleared, is called Fizz Recruit. If you look at it, not only will it calculate the IPH, or the intraparenchymal hematoma volume, here given as 10 cc's and outline it for you, it will also give the intraventricular hemorrhage volume, in this case 20 cc's. It will also calculate the midline shift, denoted as 3 millimeters here. Next patient is an 89-year-old who had a CTA of the head and neck aorta to evaluate for carotid stenosis and planning for middle meningeal artery embolization for chronic subdural hematoma. Now, this is one of the cases I showed you before, and you have the current images on the top and the prior on the bottom. And this is typically how we view things in the axial and coronal, and you're always trying to get a good measurement. Where am I finding this subdural that it's most fair to measure at, and it's not obliquely measured? So you could spend a lot of time measuring these subdurals. Using the Biz Recruit, again, investigational use only, not only can they calculate the thickness, give it as 16 millimeters here in both the current and prior study, but it was also able to give the volume of subdural, because we know subdurals can migrate and redistribute. So the subdural collection was 115 cc's here, whereas it was 100 cc's before. But let's go back to this patient. This wasn't just a brain CT. Remember, they ordered a CTA for the head and neck angio. Well, it detected the ICH, but it also detected an aneurysm on the CTA, and it goes to the slice of interest. Now, when we go back, we can look and see there is a right middle cerebral artery trifurcation aneurysm. Here it is pointing superiorly and anteriorly. Now, when we get our CTA images of the head and neck, there's a lot of images to go through, plus the nice, pretty 3D reformatted images that the technologists give us. I calculated we have over 600 source images for CTA head and neck alone, plus 64 images for the CT brain. That's just using single window without recons, yet we know we use those, plus countless reformats. We could really use the help in discerning things. So now that we know where to look for that aneurysm because of the aneurysm detection algorithm, you can now see that irregular right MCA aneurysm in both the 3D reformatted displays. In general, how good are radiologists at picking up aneurysms on CTA and subarachnoid hemorrhage? This was a study back in AJR in 2011. It looked at on-call residents. Granted, it's not attendings or neuroradiologists, but these trainees really deserve the best, as well as our patients deserve the best care. Now, these are head CTAs alone. This does not include a neck, so they're not being distracted. And they're also subarachnoid hemorrhage, so they know they're looking for an aneurysm. And even given that per aneurysm, resident sensitivity and specificity for detecting aneurysms of any size were 62% and 91%. The PCOM, posterior communicating artery, and internal carotid artery aneurysms were blind spots with aneurysms 3 millimeters or larger detected with sensitivities of only 33% and 50% respectively. Again, we could all use the help. This is just out in the Journal of Neurosurgery, actually came out 2 weeks ago. Validation of automated machine learning algorithm for the detection of analysis of cerebral aneurysms using this algorithm. They had 400 patients. For aneurysms greater than or equal to 4 millimeters, it had a sensitivity and specificity of approximately 94%, positive predictive value of about 88%. If you look here, it's very nice to get the heads up that you're dealing with an aneurysm. So now let's go below the neck into the aorta. Biz AI uses deep learning to find aortic dissection. It isolates the aorta from the rest of the study and searches for dissection flap from the aortic root all the way down through the iliac bifurcation. If there is a suspected dissection, you will get a push notification. How quickly, you ask? Average picture to notification is 36.5 seconds with a high sensitivity and specificity of 99 and 98% respectively. So here's an example of a patient where the algorithm picked up an aortic dissection and it goes exactly to the slice, and you can see the flap right there. Now we could go and look at all these source images and you could see the dissection flap in the ascending aorta as well as in the descending aorta. And now you could also see these curved reformat image that shows the dissection flap nicely for all the way from the ascending aorta down to the iliac arteries. Now I ask you, do you really want this case sitting as the 15th case down on your stat list? I would say absolutely not. Biz PE, there is now an algorithm to detect pulmonary embolism and find the clot in the pulmonary artery. The clot in the main and segmental pulmonary arteries is detected and you will get a push notification. This time it's about 63 seconds, so just over 1 minute, and the whole team can actually get the alert. Sensitivity and specificity are 91% and 92% respectively. Let's look at an example. Here's a patient with a saddle embolism. We get the alert, we get that PE alert. The PERT alert, or pulmonary embolism response team alert, goes out to the entire PERT team, simultaneously notifying the team rather than in serial fashion and beginning that coordination of care. It will also calculate the important RV to LV ratio, which under normal circumstances, I'm told, should be under 0.9. Here it's 2.25. Not only will it give you the ratio, but it'll show you where to measure the ratio from. Here's the source images from that same patient. You could see the large saddle embolism going into the main pulmonary branches. And here it is on oblique reformatted images in the right and left pulmonary arteries. This patient goes on to pulmonary angiography with Dr. Gandhi, does the angiogram, sees the large clots, goes in with thrombectomy catheters, and you could see an improvement on the post-pulmonary angiogram. There was successful pulmonary artery angiogram with mechanical thrombectomy of pulmonary embolism with substantial thrombus removed. Pressure measurements dropped from 52/19 to 42/9. Here's the patient's follow-up. Decrease in pulmonary embolism burden, as you could see on these images, and also the RV to LV ratio is now 1.18. Remember, previously it was 2.25. So how important is it alerting the team at the same time, having this pulmonary embolism response team on patient mortality? Well, this was studied in the American Journal of Cardiology, and they looked at PERT associated with improvement. They found a reduction in mortality through 6 months, 14% post-PERT versus 24% pre-PERT, relative risk reduction of 43%. Reduced length of stay, that's 6.5 days post-PERT versus 9.1 days length of stay pre-PERT. The time of triage to diagnosis of pulmonary embolism was independently predictive of mortality, and the risk of mortality was reduced by 5% each hour earlier the diagnosis was made. So not only do we want to get to these images earlier on our work list, but we want to get it to the team simultaneously as quickly as possible. Now you may ask, I'm getting all these alerts, what if I don't want them? Well, you could customize each alert from having no alerts to silent override. So if you have your phone on silent, it will even override it if you choose to. You could do it for CTA, LVO, ICH, RV, LV, PE, aortic dissection, you name it. So why is it useful to have redundancy in having both a mobile and a desktop app? Well, number one is I'm not always at my desk. Sometimes I have to get food. Sometimes I even go to the bathroom. I need a mobile app. Not everywhere I read has good Wi-Fi or cell signal, so I definitely need a desktop app as well. Sometimes our internet or PAX goes down. I definitely need the mobile app with cellular service. Communicating and visualizing is easier on a large screen, so that's Advantage desktop app. I forgot to charge my phone last night. That sometimes happens. Advantage desktop app. We want to communicate with clinicians and other members of the care team. They need the mobile app. So therefore, we want and need both. Thankfully, currently the Viz AI platform does have both. It has the mobile app and a desktop app, and it is now able to integrate into work lists as well. So with that, I thank you for all your time and look forward to the questions.
All right, thanks so much, Dr. Bash and Dr. Abrams. Appreciate it very much. We've got some good questions coming in here, so why don't we get right to it? For Dr. Bash, with so many radiologists in your imaging enterprise, how do you get everyone on board to adopt these new technologies?
Yes, that's a good question. We have about 800 radiologists. And so you could imagine it's a fairly big feat to get a new AI technology on board where all the radiologists feel trained and comfortable with it. And so we've tried different approaches and both have had their advantages. So for example, when we incorporated the AI tool of quantitative volumetric imaging about 17 years ago, I did educational webinars, and then all of our neuroradiologists would log into that and they could get a feel for what the AI technology is and how would they incorporate that in their report. And then as that technology improved over time and as we hired new neuroradiologists, I did another webinar and they could log in whenever they wanted to, but also get a feel for what's new and train the new people. Now, when we incorporated deep learning for image reconstruction throughout our imaging enterprise, we took a different approach. Our Chief Technology Officer and Vice President instituted pilot programs on both the East and West Coast. This type of technology was used by all 800 radiologists, so that's a very large number of people. And the images look different because it's improved signal to noise ratio, contrast to noise ratio. It has slightly smoother appearance. And so we really wanted to make sure that everyone was on board. Now, before implementing any AI tool, I forgot to mention, we always get IT involved. So everything is all completely ready to go by IT before we ever introduce to the radiologist. But then in this, for deep learning, the pilot program that he instituted, he had the heads of sections on both the East and West Coast look at the standard of care image. And as a patient came in, we'd randomly choose one sequence where they do the standard of care and then repeat with a fast protocol and apply deep learning. And then the section heads would compare side by side, and they felt very, very confident and convinced that the deep learning, the fast DL images were far superior to the standard. And then that excitement kind of trickled down through their section. So by the time we implemented throughout our entire enterprise, all of the radiologists were really on board, and it really turned out to be a seamless integration. And we used a similar strategy when we applied the deep health, deep learning for breast cancer detection on mammograms. So started with the section heads and then trickled down through the rest of the breast radiologists on both East and West Coast. And that seemed to be a very effective way of implementing. Those are just a few examples, but that's how we sort of have handled it.
Right. So it sounds like a little bit of work on the front end to make sure that everybody's engaged and aware of the implementation and the value that the products can bring. But it sounds like, once you start to see some of the benefits of this, it's kind of a no-brainer and folks tend to go with it.
Exactly.
Excellent. Thank you so much. Let's see what else we have here. Dr. Abrams, you mentioned communication. There are many other tools out there, for example, WhatsApp or Teams. Can you talk a little bit about how you've seen this communication work for you and anything that you think might be notable?
Yeah, well, that's a great question, because we actually didn't start with Viz AI for the AI aspect. We actually started with it because of the communication aspect. We were having a difficult time communicating with the team. We have 9 emergency departments that feed into our one comprehensive stroke center. So we would try and use WhatsApp because it was encrypted. However, you don't have the patient's information in there, so you don't know which patient you're talking about. A lot of people have similar or even the same names, and we could have multiple strokes going on at the same time at different hospitals or even at the same hospital. So we needed that patient information to be going along with this type of communication. The other thing it allowed us to do was actually get the images to the referring physician so they could also decide what to do. Once we got that, and they started showing us what else the app could do, I was a little bit skeptical because I'm a contrarian by nature. And so they were saying, but we have this LVO. I'm like, yeah. And then I started using it. I'm like, wow, this is really good. It's not only picking up M1s, it's picking up M2s. This is pretty good. Then they said, why don't you try our hemorrhage app? I'm like, you know what, I'm going to hate it, but I'll give it a try. We'll do a 3-month demo. We did a 3-month demo, and I said, I was really shocked on how good it was. And even when my partners said, we need to, do a paper on this, I can't imagine that it would have been this good. And now we're looking at the aneurysm detection. And as I showed in my talk, that's really good as well. So I think a lot of this technology has come a lot further than I personally expected. And again, it started out more as we needed a communication tool, which now we have, but now we have AI tools that are very helpful for our workflow.
Okay, so another related question, how does the chat function bring the radiologist into the arena with fellow members of the team? So something similar, but do you feel it changed the way you interacted with other members of the care team?
Yeah, so we used to do it, I guess maybe you'd call it a little old fashioned. It would always be a phone call to the neurologist to give the results. And the problem with that was sometimes the neurologist is doing the stroke or telestroke and they don't pick up, and then you're waiting for them to call you back and you're starting to get busy with other things. Now we have a telestroke company that we work with that when we started with them, they said, guys, can you stop the phone calls? We'd rather you just text us on the Viz app, because they had it. And that thrilled my colleagues. And they said, that's great. We could just type it into, whether it's on your desktop or on your phone, you could type in the results, they get it, they say thank you, and you're pretty much done until they go on to the CTA and CT perfusion. So it's really been a big time saver for us. Now, if it's a very complex case, sometimes I still will call to discuss verbally, but I'd say over 90% of the cases now are just gone through the chat function. And we've actually also improved our door-to-device times as well.
And I'd like to just add something to that. Communication is one of the biggest pain points for radiologists. And, you see it in the hospital, but you also really see it in the outpatient setting as well. Well, we don't see as LVOs in the outpatient setting. At least we don't like to see LVOs ever in the outpatient setting, but we do have urgent findings that need to be communicated. And trying to track down the referrer when you have an urgent finding, particularly as some of us are working off hours or we're dictating late at night, it is very hard to sometimes get a hold of. And if the referrer is at the hospital, it's paging all over, and it can be very difficult, and it can also cost a significant amount of time. So I think one of the things that Viz really did right from the beginning was this communication tool to help alleviate that significant pain point for radiologists.
Thank you. So we have another question here. I think, Suzie, this would be great for you. Could triage apps like Viz play a role in the private practice setting?
Yeah, so as we talked about, there are certain AI tools that are more amenable in the outpatient setting as opposed to the inpatient setting, and some really have crossover. So there are certain modules within Viz AI that could be very important in the outpatient setting. So we see there's, almost not a single day that goes by that I don't see some aneurysm. Now, not all of those are CTAs. A lot of those are discovered on MRA as well, but we still do CTA for aneurysm screening and for other screening where aneurysms just happen to show up. So it's a very common thing to see aneurysms. That is something that can be used in the outpatient setting. The other thing is for intracranial hemorrhage, acute subarachnoid hemorrhage and acute parenchymal hemorrhage, we sometimes see in the outpatient setting, although not nearly as frequently as in a hospital setting. But subdurals are something that we follow all the time. And again, we follow those with both CT and MR, but we see a lot of routine, follow-up CTs in the outpatient setting for subdurals and ordered by our neurosurgeons. And having that kind of tool available, although it's still in the sort of the research module, but, being able to calculate the volume, as Dr. Abrams was saying, is a very important thing for subdural hematomas, because again, where do you place your measurement tool? Where I place it is probably not the same place that my colleague placed it before, which is why it always requires us to measure and then remeasure on the prior ourselves, because it just doesn't necessarily match with what our colleague said. So again, volumetric quantitation of the subdural is very important and would be a great tool in the outpatient setting.
Thank you. I'm just going through the questions here. Dr. Abrams, we know that AI can provide, false positives or false negatives. Is there a way that you generally provide feedback?
Yes. So like I said, I was more of an AI skeptic in the beginning than I am now. And one of the things I wanted to know was, how do I give feedback saying, oh, this missed an LVO or it was a false positive bleed or something like that. What I like about the app is you can actually just go to contact support. You type in, or you could just voice in and say, missed M2 LVO, and you just hit send and they'll send you back an email looking into it, and then they'll respond with an email saying, oh, we're updating the algorithm due to this case. And I will tell you, when I first started doing using Viz, which is I guess about 2.5 years now, it almost never missed an M1 occlusion, but on occasion it would miss M2s. Now it very, very rarely misses M2s. And I hopefully think that it was related to all the feedback that we give so that they can get the data and update the algorithm. So I would say the algorithm, I could see in the 2.5 years we've been using it, has constantly improved.
Excellent, thank you. So it looks like we're right close to the end of the hour here. I'd like to thank Dr. Bash and Dr. Abrams again for joining us. We really appreciate everyone's time today. It's been a great session and look forward to hearing from you both again.
Thank you.
Thank you for having us.
Thank you.